Thanks very much. Hopefully you can see my screen and you can hear me. Do pipe up if there's any issues. So hello, I need to share something with everyone. Today I am 21 years an analyst in the NHS. It is my 21-year anniversary this very week in the NHS and NHS adjacent analytical roles. Mostly NHS, bit of time in the charity sector, but I stayed in touch with the NHS, and actually seeing Karen reminded me we did together teach an MSc quality improvement module, and we both talk very quickly. I'm sure those students had the best time. But I currently work for UCL Partners, which is a health innovation network covering North Central London, North East London, and Mid and South Essex. So a really diverse patch. And it was a bit of a change in focus to me moving into this role, because it was about establishing an evaluation team, very different from my previous gigs, which was very much kind of quantitative analyst. My background is in statistics and research methods. So this was quite different. But what has become absolutely apparent to me in the just over a year that I've been at UCLP as their Director of Evaluation is that it still plays a huge role in improving patient care. So what I want to kind of chat to you about today is, it's a soapbox, but I promise I'm not going to stand on it very long, because for brevity, I'm going to summarize how I think evaluation has a role to play in improving patient care through the medium of just four cartoons and 2 practical examples of work that we're engaged with at the moment. So let's start with cartoon number 1, which is about what we often imagine evaluation to be, and certainly things that I imagined evaluation to be before I really got into the nuts and bolts of developing a team that did it. Writing lots of big reports, generally quite long ones that can prop up tables, using data, and very much evaluation as a bit of a foregone conclusion in many cases. So just demonstrating how awesome we are. And if it doesn't look like we might be awesome, then perhaps letting that evaluation report drift onto a virtual bookshelf somewhere and gather virtual dust. So we tend to often lose the lessons from programs and projects because we don't historically do evaluation particularly well. It's often seen as the preserves of external specialists, academic institutions, specialist contractors, which for sure maintains independence, but doesn't always necessarily give us the kind of rapidity and the kind of immediate lessons that we could potentially learn from doing really robust evaluation and the analytics that are within that. So that's kind of what we might imagine evaluation to be. I'm sure there are people in the room who go, what nonsense are you talking, Kate? Of course, evaluation isn't like that, but we don't think of evaluation that way. But what evaluation can be is, as I said, rapid, based in the real world, and really embedded in what we term learning health systems. So approaches where health systems can really utilize the information from evaluative work and analytical work on the spot, feeding it back into what they're actually doing to improve care as projects go forward, as programs are moving forward, very much kind of in line with all the messages that have come from both Joe and Karen so far. But the real world is really messy, and evaluating outcomes, particularly kind of big ticket impact items, if you like, in the real world is not always very straightforward. So whilst we're really keen in the evaluative world to deliver with rigor, so we want that top quality, gold standard evidence wherever we can get it, it really needs to be able to be applied in the real world. And as this cartoon illustrates, if we're kind of entirely reliant on the kind of clean and neat, high standard of evidence that comes with RCTs, for example, we're only going to be guaranteeing to help a really potentially quite a small number of people. And given what we know about the representativeness of our research cohorts, potentially embedding inequalities as well. So coming back to Karen's question earlier, it's not just about whether or not we made a difference, it's whether or not we implemented what we set out to do well. And that's the nub of really supporting systems to become learning health systems. So we do need to ensure that we use rigorous methods, and we do need to think about how we can ensure systems genuinely learn lessons from the implementation, as well as from whether or not something delivered what we expected it to from an outcome perspective. So the focus is really on understanding the why, and evaluation can help us understand that as well as the what, so that we can learn, apply lessons locally, and ultimately support some of that spread and adoption that we've heard as a theme really throughout all of the talks so far. Come on, slides. There we go. Right, cartoon number 3. What's all of this got to do with data? So yeah, that sounds great, Kate. You're an evaluator. Lovely. You've developed an evaluation team. This is the we're extolling the virtue of evaluation, but what's that got to do with us as analysts? Well, obviously, evaluation is based on good evaluation only happens if you've got good analysis, and that only happens with good data underpinning it. I'm guessing that not many people in this audience would consider themselves evaluators, but really, you absolutely are. Certainly can be. Come join us. This kind of real world evaluation work that I'm talking about is often mixed methods as well. And certainly my team is a mixed methods team. So that means bringing qualitative and quantitative methods together to form a holistic view. And one of my reflections from the past year of developing this team, leading this team, has been talking to my kind of very, very expert qualitative colleagues, and I hasten to add, not my area of expertise at all. I've been really, really struck by not only the kind of rigor of the methods that they undertake, it's not fluffy in any way, shape or form, but I've also been really struck by the benefit that their insight can bring to how I structure my quantitative analysis, how I plan that, how I think about it, how I look at it from different perspectives. So this multidisciplinary approach, utilizing people with qualitative skills as well as skills, and within that you've got multidisciplinary. Those are two kind of very broad brush areas. So within my quantitative team, for example, we've got economist, we've got a statistician. Within the qualitative side, we've got people who are more interested in kind of participatory methods compared to more kind of traditional approaches. So these multidisciplinary approaches give rise to really interesting and exciting insights. And I've kind of, the kind of dyed-in-the-wool quantitative analyst, constantly challenged and impressed by ideas and approaches from my qualitative colleagues. They also consider my R scripts as kind of some form of witchcraft. So we're bringing together these very different viewpoints, and it means that we can collaborate on really some really complex problems, and we work in a complex system, right? Bringing data in all its forms from all sorts of different places. And what's really nice about that is that obviously it gives us an opportunity to embed ourselves in and seek input from a really broad range of people. So I've already kind of hinted at this, and I know that I'm preaching to the proverbial choir in terms of the importance of high quality data and analytics when it comes to actually saving lives. We've all seen the hashtag data saves lives, and actually, it's not necessarily data itself doing that, it's the analytics and the interpretation of it that really makes the difference. So as real world evaluation, because it's in the real world, it's quite participatory in nature, and becoming more so because we've got more and more opportunities to do that. Mass collaboration platforms are evolving all the time. We've got lots of opportunities for people to engage in a whole wide range of ways. And we want to hear from patients and public stakeholders and what matters to them. We want to hear about staff experience, how their care, how their delivery of care, and indeed the care received by patients and public stakeholders has changed as a result of the work that our colleagues, clinical teams, implementation teams, whatever, are actually doing. So that helps us really develop meaningful analyses that speak to a really broad audience. And Joe's presentation was an excellent example of the importance of doing that. And different people want to ask different questions, and the patient and public stakeholders that we involve in all of our work, so throughout the whole of our evaluation life cycle, ensures that they're an integral part of our audience as well. And it gives rise to some really exciting opportunities for analysts to demonstrate their impact. One of the things that's kind of driven my job choices, I guess, over the past 21 years has been being able to have a clear line of sight to the impact that I've made. And there's some jobs I've had to squint a little bit and look around a corner in order to find that. But on the whole, that's something that I've seen. And what's really nice in the evaluative space, particularly in this real world environment where you're feeding findings back very, very rapidly, is that it's really blindingly obvious, both in immediate terms and also in the longer term, the impact that you're having in terms of demonstrating outcomes or impact, or indeed helping to kind of course correct particular programs of work as we go. Right, that's my 4 cartoons done. So I'm going to give you a couple of practical examples of work that we're doing at the moment, which I hope illustrate some of the points that I've made in terms of how evaluation can support improved patient care. So here is example number 1, and I'm going to flip between 2 slides so you get a bit of a sense of what the program is. So this is an evaluation of a program called CVD Action. CVD Action is the pithy name with its own logo of a smart data tool, is the strapline. It's been developed by UCL Partners, and it's designed to support GP practices and primary care networks to deliver a step change in preventive care for cardiovascular disease. So basically preventing heart attacks and strokes at scale. And what CVD Action as a product brings together all of the key metrics for CVD prevention into one place. So integrating the results of about 85 primary care searches into a kind of, the idea is very user-friendly, very actionable, interactive dashboard. I'll show you what it looks like in a second so you can have that in your mind. And the idea is that that sits with, alongside the proactive care frameworks, which are a kind of set of frameworks to support primary care networks and GP practices to prioritize patients and then undertake pathway transformation. So to improve clinical optimization that might be delivered by a nurse, a pharmacist, a GP, like across the whole network, primary care workforce, and deliver that kind of that care optimization to help prevent those heart attacks and strokes. So let's show you what this thing looks like rather than me keep waffling on about it. So this is the, come on, there we go. Here's the CVD Actions dashboard. This is all dummy data, by the way, so I'm not breaking any rules. Here is the home screen, and you can see here we've got 6 of the 6 high-risk conditions, hypertension, atrial fibrillation. I won't read them all out. If you drilled into, for example, hypertension, so cast your eye over towards the right of the screen and the kind of red bars, these are kind of drilling down into a deeper breakdown of the metrics around hypertension. So that might be looking at hypertension not treated to target. It might be looking at the proportion of people who have hypertension who already have cardiovascular disease who are or aren't on a lipid lowering therapy, et cetera, et cetera. So very clinically valid, believe me, to the nth degree, very well, very clinically signed off to the last scrap of code. And at the practice level, so if you were accessing this at a practice level, you could then drill down to see the list of patients. So you have a similar principle to what Joe was showing around the asthma dashboard earlier, being able to identify those patients, bring them into clinic or manage them however you want. Now, there's 10 people in this particular dummy data set who have a BP of over 180 over 20, which is really, really bad news indeed. Anyway, that's what it is. How are we evaluating it? And we're evaluating it in 2 parts. And this is the kind of multidisciplinary piece that I was talking about earlier, this mixed methods principle. So on one side, we've got a qualitative element, which is about the implementation. How is this landing? What are the practical issues? What are the practical barriers that we're finding to getting this stuff rolled out? No one mentioned information governance too loudly. Is it feasible? Does it work in the context of a day-to-day? I will stop after this. I won't give you my second version. My second example is fine. Does it work in this kind of in the day-to-day workflow of a GP, for example? And then in the outcomes evaluation side, much more quantitative in nature. So we've got a real focus on hypertension and cholesterol. We have we're doing a difference in difference design alongside a time series analysis. And don't worry, Karen, it is SPC. So bringing all of that together with a range of really interesting, different methodologies, different expertise. I'd never heard of a Euclidean distance matrix before I started work on this project, but it's been a revelation for a whole range of reasons. Applying all of that together has given us the beginnings of, because it's still quite early on, some really insightful, useful, and used insights that are making a genuine on the ground, both to the primary care teams and to the patients that they're caring for. I'll stop there. Thanks, Connor.